Good morning, ladies and gentlemen. Thank you very much for coming so early on Saturday morning. Now, I'm trying to present an overview of sudden cardiac death and our experience within the UK, and I hope that will be a useful opening to the rest of the day. Now, let's first start with some definitions to make sure that we're all discussing the same thing. As Professor Sharma said, we'll predominantly concentrate on the young sudden cardiac death, although we do see older individuals in our clinic, and by young we usually mean by the age of 35. And then when we discuss sudden cardiac death, obviously we mean non-traumatic deaths, and there are two types of sudden cardiac death. It's the ones that the pathologist will be able to identify specific condition like hypertrophic cardiomyopathy, coronary artery disease, and the ones that the pathologist looks hard and long in the heart, but still he cannot identify any pathology and declares it as a normal heart. And those are the deaths that we call sudden arrhythmic death syndrome. And those sort of deaths are predominantly due to arrhythmias because of inherited arrhythmia syndromes such as the long QT and Brugada syndromes that we'll discuss later on. Now, the epidemiology of sudden cardiac death in the young is not well established, and it's not well established because there are different sorts of research with different age groups, different populations, so it's not quite homogeneous, and it's very difficult to ascertain exactly what is the incidence of sudden cardiac death. Estimates can vary from anything to 2 per 100,000 per year in American collegiate athletes, that they were less than 35, to up to 13 per 100,000 per year in US military recruits. In a significant proportion of them, no cause is identified, and that such deaths is becoming a predominant feature now, and we'll discuss it in just a second. Also, there is a male predominance, and that's quite striking, not only in the general population, but particularly in the athletic population, where the proportion is almost 9:1. And then there are discussions whether the ethnicity impacts on sudden cardiac death, and there are such suggestions, for example, for individuals of African or Afro-Caribbean descent, whether they're more prone to sudden cardiac death from conditions such as hypertrophic cardiomyopathy. And this is the sort of table that you usually are presented with, and this is predominantly from American data. And it's important to note that those are predominantly based on post-mortem reports, and not the actual pathological findings. And you can see that sudden cardiac death is predominantly due to congenital or anatomic abnormalities. Cardiomyopathies play an important role, and then you've got other causes like arrhythmias. And you can see that in this particular table, the normal heart is only 1%, which is not what we find here. So I will start briefly with a study we performed, and we examined the death certificates and the causes of death from the Office of National Statistics in England and Wales. And we examined the deaths between 2002 and 2005, so 4 consecutive years. And what we did, we went back to the ICD classification, and we identified causes that we thought would indicate a cardiac cause of death. And we classified in class A1 if we thought that that's likely to represent a sudden arrhythmic death syndrome. And you can see cardiac arrhythmia unspecified, pre-excitation syndrome. Class A2 and class A3 if we thought that that's likely to be due to cardiac death, and you've got the dilated cardiomyopathies and more non-specific causes in A3 such as heart failure, congestive heart failure. And then, as you can clearly see, we included a class B as well. And you may be surprised to see there epilepsy or status epilepticus and drowning. But as you probably all know, there are suggestions, there are increasing suggestions that people, for example, with ion channelopathies may present with epileptic type attacks. And these days, neurologists are more likely to do an ECG compared to the old days that they will never think about it. And also, syndromes such as long QT syndrome, for example, may predispose to drowning in athletic individuals. So, according to the study of those death certificate-based review of the ONS data, the incidence of sudden cardiac death was about 1.8 per 100,000 per year, which equates to about 8 young deaths per week. And the incidence of SADS, so the class A1, which is the normal hearts, is 1 young SADS death per week. As with previous studies, we did find a male predominance. And importantly, you can see that in the class B, there was a similar sort of prevalence of those epileptic or unexplained drownings, which was, again, about 8 young deaths per week. And taking into account our results of 8 definite sudden cardiac deaths, and making an assumption that about 20% of deaths from class B could be potentially because of arrhythmia syndromes, that's how we came up with the 12 young deaths per year in the United Kingdom. Remember that our data did not include Scotland and Northern Ireland. And those are the causes. This is the pie chart from our study, and you can clearly see in red that the ischemic heart disease predominates. And then we've got a big patch of different cardiomyopathies. We've got the potential SADS deaths, myocarditis, valvular disease, and other conditions. And I would just like to draw your attention to the part, to this part here. And you can see that the death is attributed to atherosclerotic coronary artery disease. And the question is, what does that really mean? Is that a death because of myocardial infarction, or is it a death because they found a bit of atheroma in the coronary artery? And it is an interesting question that will come back in just a second. And those are the deaths in class B, and you can see that the majority of them are because of unspecified epilepsy, and then you've got drowning and other unspecified causes. And we're particularly concerned about this pie chart, and we're particularly concerned as to how many of these deaths could be of cardiac origin. And this is a study that we performed with Dr. Shepard and Sofia De Noroya from Royal Brompton. And they examined essentially consecutive, not professional athletes, but athletic individuals that were referred to Mary Shepard for a post-mortem examination. It was almost 120 of them, majority of them males, as you will expect. And the great majority were less than 35 years age. The mean age of death was 28 years. And almost 20% had a family history of sudden cardiac death or cardiovascular symptoms such as chest pains, palpitations prior to their death. And that brings you to the point that Professor Sharma was just alluding to as to the importance of recognizing that family history and recognizing those symptoms. And you can see that this pie chart looks quite different from the very first one I introduced to you. And again, in the different shades of blue, you've got the potential cardiomyopathies, some coronary artery pathology. Significant coronary artery disease was about 3 cases, and that was confined to individuals greater than 35 years of age. The other 3 or 4 cases were coronary artery anomalies and were in younger individuals. And then you've got this big piece here, almost 25%, where Dr. Shepard was unable to identify any cardiac pathology, and believe me, she does look hard for it. And the other issue I would like to address in this particular pie chart is this idiopathic left ventricular hypertrophy, because this is an interesting question. What idiopathic left ventricular hypertrophy means that you identify hypertrophied ventricle, but you're not happy to label it with hypertrophic cardiomyopathy because you're not able to identify the particular pathological hallmarks, and in particular myocardial disarray. And the question is, what does that represent? Is it a form of hypertrophic cardiomyopathy? Is it an athletic individual with hypertrophy that went wrong? Or is it an incidental finding, and those deaths could be because of an ion channelopathy, for example? And those are very interesting and intriguing questions. And I'm particularly proud of this study, which hopefully will be published soon. And what we did this time, because of our experience of getting families throughout the United Kingdom, what we noted is that there were a lot of requests for non-specific pathological findings. So essentially, you either have a post-mortem that it's definite of pathology, and the pathology say it's definite hypertrophic cardiomyopathy. You may have a pathologist that it's certain that it's a normal heart, so you classify that SADS, and you're looking for an arrhythmia syndrome, such as Brugada syndrome or low QT syndrome. But there is this gray area as well, and that gray area can be comprised of mitral valve prolapse. We all have heard that mitral valve prolapse can potentially predispose to sudden cardiac death, but on the other hand, you all know that mitral valve prolapse can be present in 1 to 2% of the general population. So how significant is that? We just discussed left ventricular hypertrophy in isolation, so I won't go through it again. You've got all these lymphocytic infiltrates that are labeled as myocarditis, but how hard are the signs of myocarditis when a pathologist looks at the heart? And then you've got this finding that, believe me, it's very, very common when you read the report of a death of a young individual, and it says coronary atheroma. How significant is it coronary atheroma of 40 or 50% in a young heart? Can you really attribute the death to that unless you've got strong signs of myocardial injury and myocardial death? So essentially what we did, we had our group 1, which was the definite pathology, so we took those out. We had the normal autopsy as such, and we had these autopsy findings of uncertain significance, which is about 12% of our cohort. And we went on to investigate the family relatives, the surviving relatives of those deceased, and find out, after comprehensive investigation, whether we could identify a potentially inherited condition in one of the relatives that visited our clinic. And after comprehensive evaluation, these are the pie charts, these are the diagnoses that we get. So this is the SADS families, so the individual died with normal post-mortem, and you can clearly see that a lot of them are diagnosed with an ion channelopathy and only a small proportion with an underlying cardiomyopathy. And this is the pie chart from those individuals who died and there was an uncertain finding, a bit of fat infiltration, a bit of query myocarditis, a bit of coronary artery disease. And you can see that those two pie charts, they look identical, indicating that actually those sort of individuals should be investigated in the same sort of way as individuals with a normal heart. And the pathological findings should not misguide you towards a diagnosis of potential coronary artery disease death or a death because of mitral valve prolapse. And this is a very, very important point. And this is just the breakdown, essentially, as you can see it on the white chart, of the different pathological findings. And then you can see in blue the ones with ion channelopathy, the families with cardiomyopathy in green, and in gray the undiagnosed families. And you can clearly see, for example, that with minor coronary artery disease, out of the 6 individuals whose families were evaluated after their death, we diagnosed an ion channelopathy in 2 of them. The other option could be that the results are interpreted as coronary artery disease and their family relatives get advice regarding smoking. They probably will get a cholesterol check to exclude familial hypercholesterolemia, and they wouldn't be screened for such condition. Another example is that myocardial infiltrate, which could be interpreted as potential myocarditis. And finally, and most importantly, those pathological findings that are sometimes interpreted by non-specialist pathologists or by the doctor who is reading the post-mortem report as cardiomyopathy. And this is important because then you put the question, does the family have hypertrophic cardiomyopathy? And if the specialist goes down that route, he may miss the ion channelopathy that is underlying. And this is very important because secondary prevention is possible, and we know from studies that have been performed by Dr. Baer as well that you can diagnose up to 50% of individuals. So it's important that you identify the SADS death, and it's important that you refer their family relatives for detailed, comprehensive evaluation in a specialist center. And this is the route usually the family has to go through. And you've got the police, the hospital, the coroner, the pathologist, and the general practitioner. And the first question is, who is coordinating that process? And the honest truth is that no one is really coordinating the process. And although non-specialist cardiologists, for example, or general practitioners may be wondering, is that relevant for me? It's definitely relevant for you, because at the end of the day, the buck usually stops with a GP. You will be the one who may get the post-mortem report. You will not necessarily have guidance as to what to do with it. You may well have to interpret it, and you are the ones who are going to refer them for evaluation in a specialist service. And CRA is trying to address most of those issues and guide through that process. So in conclusion, ladies and gentlemen, the incidence of sudden cardiac death appears to be around 2 per 100,000 per year, but I'm pretty confident, to be honest with you, that this is a great underestimate, because as I told you from our findings of post-mortem certificates, is that SADS is 1 per week. We get a SADS referral in our clinic only per week, and we're not the only center in the whole of the United Kingdom. Secondly, a large proportion of sudden cardiac deaths is secondary to inherited cardiac diseases, and that's what makes familial evaluation so important. Comprehensive cardiac evaluation of 4 first-degree relatives of young victims of sudden cardiac death is absolutely necessary. It's not recommended, it's necessary. It's an opportunity that we cannot afford to miss. The term natural cause of death, and just leave it at that, it's not enough anymore. And it's important that you attempt to request some sort of expert input. If you're uncertain about what happened to the family, if you're uncertain about the death certificate or the post-mortem findings, call someone who can help you. At the very least, call CRA and will be able to advise you. And finally, do not underestimate, as Professor Sharma, the devastating impact of a missed opportunity as a clinician, that you saw a family who had a death, you missed the opportunity to refer them for further investigations, and another death happens 1 generation down the line. Because all of those deaths, ladies and gentlemen, are truly a heartbreak. Thank you very much.